It's really a great pleasure to join you here at the 2020 AACR virtual meeting. There are three studies that I'd like to talk to you about. The first, the INSPIRE 150 trial, was a trial to compare anti-PD-L1 combined with BRAF and MEK inhibition to BRAF and MEK inhibition as a doublet combination. The second study I'll talk to you about is a very interesting study from the SWOG group in the United States that randomized patients with BRAF mutant melanoma to intermittent dosing versus continuous dosing. The final study I'll discuss with you is a study of 6 weekly dosing of pembrolizumab at a fixed dose and the outcomes of that study, which I think are quite interesting. The INSPIRE 150 trial was a trial to test the hypothesis that the addition of an immunotherapy, anti-PD-L1 drug atezolizumab, to a BRAF-MEK inhibitor combination, namely vemurafenib and cobimetinib, would improve duration of response and progression-free survival compared to a placebo with vemurafenib and cobimetinib. This is a key and interesting hypothesis in the field of oncology, as the limitation of targeted therapies is the development of resistance in patients, where the limitation of immunotherapies is only a fraction of patients will respond. So could there be a high response rate with improved duration of response with the triplet therapy? The INSPIRE 150 clinical trial randomized 514 patients with advanced BRAF mutant melanoma to a doublet therapy of vemurafenib and cobimetinib with an anti-PD-L1 placebo to a triplet therapy of vemurafenib and cobimetinib with the anti-PD-L1 drug atezolizumab. This was indeed a positive trial. The triplet therapy of atezolizumab, vemurafenib and cobimetinib gave an improvement in progression-free survival of a median of 10.6 months in the control arm to 15.1 months in the triplet therapy arm. If one looked at landmark freedom from progression, there were 45% of patients free of progression in the doublet control arm compared to 54% of patients at 12 months in the triplet therapy arm. The duration of response was a key secondary endpoint. This also strongly favoured the triplet therapy arm, where there was overall a 70% increase in the median duration of response from 12.3 months in the control arm up to 16.1 months in the triple therapy arm. There was also interim analysis I presented of overall survival, which also favoured the triplet therapy arm, although these data are immature. Of course, with any combination therapy, particularly here a triplet therapy combining a targeted therapy with immunotherapy, safety is very important. Encouragingly, this triplet therapy was well tolerated, using a regimen where the first 28 days there was no anti-PD-L1 drug given, but that came in at cycle 2 of day 1, in other words, 28 days after a lead-in with the BRAF and MEK oral therapies. So that regimen was well tolerated. There was just over 12% of patients that had to discontinue the triplet therapy because of adverse events. And overall, the safety profile was very similar to the control arm, vemurafenib and cobimetinib. There were slightly increased rates of increased transaminases, plus the expected thyroid dysfunction with an anti-PD-L1 drug. So in conclusion, and the implications for clinical practice are that the triplet therapy is an active combination therapy that improves duration of response compared to BRAF and MEK inhibition alone, and that it is well tolerated and able to be given safely to patients. Also presented in the opening plenary session at the virtual AACR meeting was a very interesting clinical trial presented by the SWOG group that tested the hypothesis that intermittent delivery of targeted therapy with dabrafenib and trametinib would be superior to continuous dosing with dabrafenib and trametinib. This has been a long-awaited clinical trial in the melanoma field because some high-profile publications using preclinical models, including patient-derived xenografts, had suggested that intermittent therapy could delay the development of resistance to BRAF targeted therapy. So a very key hypothesis to try to overcome one of the difficulties of targeted therapy, namely the development of resistance. So in this trial, 242 patients were initially enrolled. Then after 8 weeks of continuous therapy, patients were randomized to intermittent therapy on a 3-week off, 5-week on schedule versus continuous therapy. So overall, 204 patients were randomized 1-to-1 to the intermittent versus continuous. The results were surprising. The results were actually that there was an inferior progression-free survival in the intermittent therapy group, with only 5.5 months median progression-free survival versus 9 months in the continuous therapy arm. So why was the hypothesis so eloquently demonstrated in preclinical models not achieved in the clinical setting? Well, perhaps the most likely reason is that the drug trametinib has a long half-life, and so potentially 3 weeks of break from treatment in an intermittent dosing schedule may not be sufficient to really change the biology of the melanoma cells in a sufficient way to recapitulate the preclinical studies. What does this mean for clinical practice? The main reason for needing to give intermittent therapy with dabrafenib and trametinib is because of disease-induced fever or other adverse events. However, in clinical practice, those breaks from therapy are very short and are unlikely to have any impact on patient outcome. So we do not have a new way of treating BRAF mutant melanoma patients with intermittent therapy as a result of this trial. And if such a trial was to be repeated, it would be better to look at shorter half-life drugs such as encorafenib and binimetinib. Another very interesting study presented here at the AACR Virtual 2020 meeting was a single-arm study of delivering pembrolizumab every 6 weeks in a fixed dose of 400 milligrams. Why I think this is a very interesting study is that from the patient's quality of life point of view, less frequent visits to the hospital can improve quality of life. And of course, very important at the moment with the COVID-19 crisis, where we're trying to keep patients away from hospitals as best as possible while still giving them the very best outcomes for their cancer. So this particular trial, the Keynote 555 trial that looked at delivering pembrolizumab 400 milligrams 6 weekly, data was presented for 44 melanoma patients. Detailed pharmacokinetic analysis was done, and safety and efficacy was recorded with at least 24 weeks follow-up of these patients. So what's notable is that the pharmacokinetic modelling of giving this dose of pembrolizumab every 6 weeks was verified prospectively in a clinical trial, and the exposure levels of pembrolizumab were very similar to 3-week dosing, with trough levels in the pharmacokinetics being very acceptable and similar to what one gets with a 3-weekly schedule. Also, the peak levels, the Cmax levels, were in fact lower than what was seen with the 10 milligram per kilogram dosing of pembrolizumab that was evaluated in earlier clinical trials. And indeed, the safety was equivalent. So overall, this was an interesting study with very similar safety to what's been recorded with other doses and schedules. And perhaps most importantly, the thing in clinical practice that we've wanted to see some data on is the efficacy. And with a 39% response rate to pembrolizumab in this study suggests that the efficacy seems to be equivalent to less frequent dosing. So overall, I think this is a practice-changing study, as less frequent dosing of pembrolizumab is clearly to the benefit of patients and clinical treatment centres alike. I think it's notable that, hot off the press, the FDA in the United States have now approved this 6-weekly schedule, joining Europe and Australia in having this now as an option for our patients.